All right, case 2. Let's take a look at another case. I'm going to give you, once again, I'll give you guys some information kind of behind the patient, and we'll talk our way through this, and maybe you'll come up with something a little different than me. Let's see what we get. So here's what the deal is. You and your partner, you respond to the report of an 80-year-old man in respiratory distress at a local long-term care facility. The nursing staff reports that the patient had been well until 2 days ago when he experienced coughing, restlessness, shortness of breath. He'd been treated effectively with an albuterol inhaler and an increased dose of furosemide or Lasix. Today the patient is much more uncomfortable and cannot be calmed down. He's also confused and cannot offer any additional history for you. So the first thing you'd like to find out probably when we get there is, whoops, hang on, I forgot to make my mark things. Make it where I can write on here. Here we go. About to get there. Patience, guys. How about some medical history? Let's find out what we're talking about. So, got a history of some CHF. Have a history of an MI. Unsure of when that was, of course. Some hypertension. Some diabetes. And then with all the other, why don't we throw in some coronary artery disease just to make sure we've got all the bases covered. Medications, well, because of the where this person lives at, there's no list available. So we're unsure other than the verbal report we were given, which was Lasix. We're unsure, as well as what he was doing some albuterol. So we're unsure, though, of any other meds other than Lasix and albuterol. Unknown about some allergies. So first thing we want to do is let's get us a complete set of vitals. Well, he's a little hypertensive. He is a little tachycardic. Let me just do this. Pulse rate's 101, respiratory rate 24. So we're seeing more and more. He might be kind of sick. And SpO2 is 88%. So when you look at him, you find an elderly man who appears ill. He is also in obvious respiratory distress. The patient is confused but cooperative. Heart sounds are normal. Lung sounds reveal coarse crackles in all fields. Intercostal and abdominal accessory muscle use is present. Abdomen soft without any palpable masses. Does have some edema present in the lower extremities. And his skin is warm and dry. So when we start putting all of this together and we start looking at this patient compared to what really, normal is, there should be quite a bit of stuff that really sticks out to us. Obviously, number one is going to be that, he's become short of breath, increasing short of breath over the last few days. He does have a history of CHF. He is hypertensive. He is low on O2, as well as he's breathing extremely fast. So we got kind of a train wreck here. So when we pull up a 12 lead, here's what you see. Let's go ahead and quickly kind of tear it apart. So we're going to do it just a little bit different this way. Another way that I showed you, which was we're going to look here, and then here, and then here, and then here, and here. So that's going to be our leads. And remember, you guys better be good at this, but in case we're not, we're going to make that for you. So we'll start with lateral. Doesn't appear to be any ST elevation. When we look at our underlying rhythm, it does look pretty messy. I do not see any P waves in a thing that I found on this rhythm, on this particular patient. It talked about this was potentially a sinus rhythm. We were not able to see because we don't have that long strip. But they talked about the regularity of the R-to-R intervals. But now you got to remember we're starting a whole new rhythm here, so it does look off, somewhere here. But when we look here, there is definitely a difference of these beats here. I don't see a P wave, We see what could potentially be fibrillatory waves. But if I had to call this something, I would probably call this atrial fib. In a deal like this, my thought process is more of like it's atrial fib until you can prove to me it's not. So let's just go ahead and we'll go against the grain, and we're going to call it atrial fib. And we do have a rate of what? 101. I know you're looking over there to see that. Rate of 101. So by definition, we do have RVR. But remember, what we're typically concerned with atrial fib and RVR is going to be up here, more little marks. But is typically we're concerned about our blood pressure because the heart is not able to pump as well, empty out its contents, all of that stuff. Obviously, he's doing quite a phenomenal job there. So let's go back to our lateral leads. Everything looks pretty good. We go to V5 and V6, although we do start seeing some elevation here. But as you can see, we've got more when we start looking around. So we go to our inferior leads. Nothing stands out with our inferior leads. Our septal looks fine as well. Now we go to V3. We see elevation. 4, it continues to grow. Up to V4, we have more elevation. 5 and 6. So when we see that, we have to, what we are assuming is, because he's having we're seeing it in the anterior leads, this patient is having a large anterior wall MI. He's also experiencing, as we talked about, he's experiencing some acute pulmonary edema. Remember, we heard some bad lung sounds and all of that. So let's talk about what we would do with this gentleman. So he needs to be taken, obviously, to the hospital. We need to probably get him to the cath lab, is what we'd all assume, right? As well as because of this, as well as his lung sounds, everything everything that we're seeing appears that he's probably in some CH, congestive heart failure. So CPAP would be a really good thing to put on as long as he can tolerate the mask. ASA wouldn't be a bad idea here because we see all of these. We see all of this elevation here. So we want to decrease that platelet aggregation if we're able to. And then probably some nitros as well. His blood pressure will take it. So nitro would be good. Obviously some O2 would be good. We said we were going to put him on some CPAP if he would take it. So we did that. We got a little IV. While awaiting the arrival of the transport unit, the patient experiences a 10-beat run of ventricular tachycardia. So he's getting sicker and sicker as we see, and he's starting to throw off some really weird rhythms. So give him some more nitro once we get into the ambulance. If you work at a place that you might have nitro paste, that's what we would do, is we went ahead and put an inch of nitro paste onto him as well. Now, there was concern about, hey, maybe, we've talked about it, and the mnemonic, Mona, remember we have, we'll just put MS for morphine, nitro, and then ASA. That's not going to be necessarily a really good idea here. No, Mona's kind of, or the morphine is kind of fallen out of favor, a bit now, especially with fentanyl, because morphine lasts so long and it has some undesirable effects as well. But we decide against morphine because of the acute pulmonary edema. So the one thing that we've seen over and over again with a patient with acute pulmonary edema and morphine is that you have a couple of things that happen many times. So the drug's been associated with increased mortality, also an increased risk of intubation, and then the potential for an ICU admission. And I don't know if most of that has to do with the decreasing the respiratory drive effects, or if it just makes them to not be able to breathe as well, or what. But we do have found several of those factors that go along with these type of patients. So this is kind of what we're looking at. Take this gentleman to the cath lab, get all of this stuff fixed up for him. So back at what we talked about, tachycardia, whether we want to call it a sinus tach or an AFib with RVR, we're looking at a tachycardia. anterior wall STEMI with acute pulmonary edema. That's about it, guys.